Hey everyone, it's Adam again, and we're going to have another lecture about epidemiology and biostats. Today, this will be a lecture about understanding some of the quality of data in clinical medicine. The objectives, which we'll cover, and more details as we go along. So it's important to understand when practicing clinical medicine, we require lots of data, and not only do we just need data, we need good data, right? And this helps us to help with everything from diagnosing your patient to determining how well they're going to do, what type of treatment we want to do, evaluating that treatment. We need a lot of good ability to analyze data that we get, both of a quantitative and a qualitative nature. And so when you're talking about kind of the inherent inaccuracies here, we're going to obviously call this error, right? And so we're going to look at a few different types of error as we go forward regarding some of this clinical data that we receive on a day-to-day basis. And we talk about errors here, we're not referring back to medical mistakes by any means, but basically we were trying to either determine, is there a difference between what was actually recorded, what our observation is, and what is actually the true value or the true result. For instance, if you were to, say, miss a spot in a chest x-ray, or, say the blood pressure cuff was misreading, either due to operator error or something like that, or, if the lab came back and mistakenly reported a chemistry value. So those will all not really be considered mistakes, but it could just be due causing error in the fact that it's the true value is not being correctly observed, right, based on what's being recorded there. And then similarly, you can have what you consider to be kind of normal ranges for things, and a patient falls outside of that, and you may think that, hey, this is clinically abnormal, but what may be normal for that patient, right? So we'll talk about false positives and false negatives, how it goes back to that. The key point, though, is that, with medical histories, your physical exam, lab values, imaging reports, they're never going to be 100% accurate. There's always going to be some limitations, either in the human aspects of it, the patient aspects of it, whatever happens to be, there's always going to be some inherent limitations here. The important thing is that we are able to analyze that data, are able to make reasonable assumptions based off of it, and make sure that it helps us to guide us when caring for our patients rather than just misleading us. You oftentimes go back to the mantra, treat the patient, not the number. This is going to be super, super important as you go forward, because again, it's easy to be misled when you're evaluating a patient if you just went off of, laboratory reports or other things like that. You really got to make sure you take the whole patient into consideration. So accuracy as a definition is going to be this ability for measurement to be correct on the average, right? So if a measurement is not accurate, means it's usually going to be biased in one direction versus another. Basically, you're going to find that it will deviate from a true value, and it may not be equally in both directions, depending on how it's being biased on how the accuracy is being affected. What also will go into that's what we call precision, or this is basically the ability to reproduce a result or the reliability of a test. And that's basically that if we were to run the same test over and over again, the ability for that measurement to get the same result, or at least a very similar result, if you, again, kept everything the same, but just repeated that test over and over again. Typically what you'll find is that if it's random error alone, especially if it's a large amount of random error, you're going to have pretty much a big lack of precision. I'll show you a picture here just in a second. But you're going to notice here that there's not really a specific bias when you have a lack of precision, because you can find that the distortions from the actual true values may occur comparably in both directions, essentially. So, for instance, if you were to look at something that was to have, say, both accuracy and precision, really when you run these tests, you should find that most of the results are going to show up right at that true value. You may have a little bit of variation here either direction, but really, if it's accurate and precise, you're going to find the true value. What you'll find if you're only accurate, so again, most of the time, on average, you're going to show the true result, but there's going to be a lot of variability here. This is something, this would be something that has a lack of precision, because you're not getting, we're getting, the data being skewed in both directions, but on average, you can see it's still accurate. Now, if you have precision only, you can have something that is very precise, but is still wrong. So for instance, the true value is lying right here, but every single result you had skewed you in one direction. You can notice here how the data is being biased on one side. And so it's very precise, but it's inaccurate. And then you can have neither accuracy nor precision, kind of the worst of both worlds, where the true value lies over here, and then the data you're getting on average is incorrect or inaccurate, and it's not very precise. So Generally, you want to have both of these. In a perfect world, you'd have perfect accuracy and precision, but you're going to find that that's not always going to be the case, unfortunately. And so with figure A, we said that accuracy is shown in the fact that the mean or the average value is true and correct in that case. And the fact that it's very reliable means most of those values that show up are going to be very close to that true value. Whereas a figure B shows one that's going to be accurate but not precise, meaning that on average you get the correct answer, but there's a lot of variability there. You're going to find that for when dealing with individual patients, there's not really a whole lot of utility in something that's correct on average if it's wrong for that particular patient. So if they're one of the ones that happens to have a value that's skewed one direction or the other, that's not going to be super useful, because again, you're dealing with a single patient, not an average of, say 100 patients. And then C was the data being very precise. You would consistently get the same results or thereabouts, but you're going to find that it's inaccurate, and thus that can be misleading in those cases. And then finally, figure D was totally useless, at the most benign or potentially dangerous, because it's neither accurate nor precise. Another really good analogy, kind of a visual metaphor for accuracy and precision, is something imagine like a bullseye, a target. And so imagine something with both accuracy and precision is on average you're getting close to that true value, this bullseye here, and not a ton of variability around the actual true value. If you're only accurate but not very precise, you're going to find there's a lot much more of a scattershot type of approach here, where things can be skewed in one direction or the other. But on average, you're still getting the true answer, the true value here, right? If it's very precise but not accurate, you can notice here a very tight kind of grouping of points here, but you're not anywhere close to the bullseye. So again, not super useful. It's pretty misleading if this is where you thought the bullseye really was when it wasn't. And then finally, neither accuracy or precision. This is probably what it would look like if I went to the gun range, but you'll notice that basically you're nowhere near the bullseye and it's very kind of scattershot. So obviously we want to find ways that we can reduce error, and there's many different types that are out there. So for instance, you can have a measurement bias, which is, we call it differential error, which is basically a non-random, systematic, it's a very consistent sort of error in which the values tend to be inaccurate in a particular direction. So imagine, for instance, if you're taking the heights of patients and all of them had their shoes on. Obviously, having shoes on would all skew the patients to have a higher to be taller, but it would be inconsistent depending on the patient. Someone who has high heels on would be measuring much taller than they are versus someone who had, say, sneakers on. And so it's one of those things where it's very difficult to correct for that bias because we don't really know how much bias is being influenced by each measurement, essentially, right? Or imagine if you had a blood pressure cuff that was reading too high or too low. All these things would be affecting your results in one direction or another, and it's very difficult to deal with that because of the fact that we don't know how much bias was affecting that particular result. Now, on the other hand, you can have these non-differential errors, which are going to be basically kind of random errors, right? So you can have the data being skewed in both directions, essentially. And the idea is if you have a big enough N, if you have enough observations, the high and the low values tend to cancel one another out. So for instance, you could try to eliminate some of that differential bias in the results by having everyone take their heights with in bare feet, right? So the shoes are being taken out of that error, so no one's being skewed higher than what they normally should be. And so again, if we're trying to get, say, like the population average height, you're going to find that some observations will be too high, some people are taller, some people are shorter. And again, by having a big enough N, you try to get the average value, because usually the outliers tend to cancel one another out as you have that regression back to the mean. There's also this concept of intra and inter-observer variability, and this has to go back to kind of the human error aspects of when we're actually doing measurements. And so the intra-observer, or the within observer variability, is if you had the same person taking measurements of the same thing, you might find difference in the measurements or difference in their interpretations, I should say. And so, for example, if you had a clinician who was doing successive measurements of blood pressure, or say they're measuring the height of the same person, there might be tiny variations therein, some being a little high, some being a little low, or say they're examining the same x-ray several times without really knowing it was the same x-ray, they might get different interpretations. We see this a lot when we're dealing with snake bite patients. One of the things you'll find, especially with like rattlesnake envenomations, is that the limb affected usually starts to swell pretty significantly. And one of our decisions on whether or not to treat with antivenom is based on how that swelling is progressing. And so you can have someone, a nurse, say measure, say the forearm of a patient who's been bitten on the finger several times, but if they're not measuring the same exact point, you may find some intraobserver variability there, where they might get a little bit of different results and may skew us towards treating or potentially not treating, depending on how they're skewing the data essentially. The interobserver is oftentimes going to be more of an issue when you have two different clinicians or multiple people who are, say, measuring the same person's blood pressure or examining the same x-ray independently, and they find different results essentially. So again, the idea is you want to have, if it's one person taking measurements, they have the same result very consistently, or if it's going to be multiple people, that they are all kind of agreeing with one another and coming up with the same interpretations of the same results. Otherwise, if you did this incorrectly, you'd have a lot of variability in the data. And so again, going back to that snake bite example, if I have multiple nurses, or say for instance, I would run into this very frequently when dealing with a snake envenomation patient, where there'd be change of shift. Shift changes in hospitals are usually 7 o'clock a.m. and p.m. So a patient would have pretty steady measurements on their, say, their forearm being measured by one nurse, and then all of a sudden shift change happens, and then next nurse comes along, didn't know exactly where the other nurse was measuring, and all of a sudden the arm looks like it's swollen, a few extra centimeters. And that could be one of those things where it's like, did it actually swell in that small period of time, or is it the fact we have someone else who's actually reviewing it and introducing some interobserver bias, right? So in the studies, especially when we're looking at things where they're doing retrospective reviews of charts and things like that, it's important to make sure that they kind of elucidate about interobserver variability and how they help to control for that. We'll talk about some ways we can do that a little bit later. So one of the things we can do to try and establish the accuracy and the usefulness of, say, like a diagnostic test or screening is to make sure that we're performing tests where we kind of know the values already. So we kind of know who has disease or who doesn't, and then have a test to see how accurate the results should be. So for instance, we would have a group in whom we know has a disease in question, and in whom the test results should be positive, right? So if I were to do, like, say, a bunch of patients who I know to have HIV, and I had a new test to test for HIV, all those should be positive, right? And then if I have a group of people who do not have the disease is absent in those patients, and then the results of that test should be negative. Again, you're going to find that not every test is perfect, and so we're going to talk a little bit more about false positives and false negatives as we go forward. Of course, there are several factors that go into the accuracy and precision of some of these tests. Now, that can include things like the stage of the disease. Obviously, earlier stages of disease are typically harder to catch. And then with your particular study population, what is that spectrum of disease? Only looking at people who are very progressive, only looking at people who are very early on. That can all influence things. And so ideally, when you're doing these tests to see how well your diagnostic test is going to perform, the patients you're going to actually use this test on should be very represented in the population in which you're testing it. So when you're trying to determine if this diagnostic test is going to be very good, it should be in a similar group of people as who you would use it in the real world, essentially. Of course, I'm sure you guys remember this, but when we're looking at false positives and false negative results, you can kind of take it back to those type 1 and type 2 errors we were talking about, where type 1 error being a false positive error or false positive result, as we'll see here, is where we are saying that a patient has a disease when it's actually they do not have it. So you're incorrectly identifying someone's having a disease or having a positive result when that's incorrect. And then on the flip side of that, we have false negative results, which are linked back to those type 2 errors or false negative errors or beta error. That's something we are saying to be false. We're saying that a person does not have the disease. We did not catch they had the disease when they actually do. Okay, so it's important to look at these tests and trying to figure out, okay, what's our false positive rate? What's our false negative rate? Because that's very important. Like, if someone has a disease, you want to catch it. And if they don't have it, you don't want to tell them they do have it. So looking at the stage of disease influencing the test results, we'll see things like infectious disease cases with HIV or TB typically are only going to be accurate after immunity has developed. So it's hard to catch those things very early on. It may take weeks to months. There's just no immunologic sign for disease very early on, and so in those tests being done very early, within the, say, first few days after infection, they would end up having a type 2 sort of error where they have a false negative result. The person has disease, but it's not able to be detected yet. Taking that same infectious disease sort of example, you can find other cases where very late presenting disease may also have a false negative result as well. You sometimes find with kind of these immunosuppressive sort of diseases, you may find that the immune system is either overwhelmed or so inhibited that you're not able to produce a false test result. So energy, meaning you have an inadequate immune system response. You can see this with advanced age. You can see this with chronic stress or severe illness, AIDS patients especially. It's one of those things where they are just not able to mount that immune response and could come up with a false negative test result. Sometimes we may have issues where we don't even realize how many false positive or false negative results we're actually getting, and which is why to consider things like the population which you're testing it in, the spectrum of disease. So for instance, with the tuberculin skin test, what they found years ago was that there's many false positives that were showing up and tended to be more common in the southeastern US. And what they realized eventually was there's an atypical mycobacteria in the soil is pretty common. A lot of these people in the southeast had exposure to. And so there was some cross-reactivity between atypical mycobacteria and then the mycobacteria tested with the TB skin test, essentially. And so because of that, because there's cross-reactivity, people were having false positive results. They said, okay, you have TB, when actually they didn't. So due to these false positive results, they went ahead and changed some of the standards for how TB tests were done. So they were replacing the old tuberculin protein with using this purified protein derivative, which is that PPD, and they used a standardized strength of these 5 tuberculin units. So that way they made sure everyone's getting just Mycobacterium tuberculosis protein, very standardized dose, and they would actually change the skin induration needed for a positive result from 5 millimeters to 10 millimeters. That made it so that it was less likely for you to get a positive result for someone who had a minor amount of induration, essentially. But again, considering the type of disease you're dealing with, the type of population, because of possible anergy with people with like HIV infection, they use a smaller diameter of induration to be considered a positive result. Because we know that they are going to respond differently, we have to change what our thresholds are for positive versus a negative result, right? And so basically by lowering that critical diameter, this helps to increase the frequency of false positive results. And so again, that's going to be an issue for people who've been immunized with the CBG vaccine, and also a lot of people over in the Southeast U.S. So again, always have to consider, what are your cutoffs for, or where are they set at, and does that make sense based on the population you're dealing with? So basically what a lot of tests come down to is that we know no test is going to be perfect, but we want them to have, good sensitivity and good specificity. This is going to come back to how many false positives and false negatives are we willing to live with a given test. And so sensitivity, we're going to talk more about this in detail, but it basically means how reliably can we find a disease when it's present while avoiding false negatives. And we want it to be specific. So we want to reliably exclude a disease when it's absent, but avoid having false positives. And so you're going to find that there's a spectrum here where as you increase sensitivity, typically you lose specificity and vice versa. And so a good analogy of this is, smoke detectors. Like we want it to go off every time there's a fire. I mean, we want them to be sensitive when there actually is fire there, but not to be not to be constantly going off when there is no fire. Meaning we want to have specificity. So a good example is like when you're cooking and accidentally something gets a little too smoky, set out the fire alarm. So that's probably not specific enough because it's not actually a fire going on, it's just my bad cooking, versus you want them to be sensitive enough every time there actually is a fire, though they will go off essentially. Now, of course, these results of false positives and false negatives just don't affect infectious diseases. You can find a good example here, like serum calcium levels, trying to use these to rule out parathyroidism. So say you had hyperparathyroidism. Basically, we know this is a disease of calcium metabolism, and in an affected individual, you should have elevated serum calcium levels. However, it can vary from time to time, depending on when this is actually tested. And so if you had a patient who has hyperparathyroidism, but the calcium did not happen to be elevated at that time, you'd say, well, calcium's not elevated, they can't have hyperparathyroidism. That would be a false negative, right? They have the disease, but you didn't catch it. Versus calcium can be elevated in lots of patients who do not have hyperparathyroidism. They have cancer, multiple myeloma. So in these cases, just because you saw someone who had a high calcium does not automatically mean they have hyperparathyroidism. Otherwise, you'd have a false positive result. So the next figure, we're going to look at some frequency distributions of serum calcium values. One of them is going to be in a population of healthy people without parathyroid disease, and then the other is going to be in a population of patients with hyperparathyroidism. And so if you have a low calcium level, say below 0.8, in the picture we'll show in a second, the patient would be unlikely to have hyperparathyroidism. And if the level of calcium were high, above point B, the patient would very likely have an abnormality of calcium metabolism. However, the rub is going to be when you have patients who fall into the intermediate range between point A and point B, just in a single test. Basically, you'd say the patient probably does not have a disease of calcium metabolism. However, you can't really rule it out. And these are the cases where serial calcium levels and then also other tests, like things like PTH levels and whatnot, should be obtained. You can kind of see that in this picture here where, say for instance, you have non-disease population. Notice here how it's still achieves that normally distributed curve. Most people will kind of fall in this range, and people below this probably be pretty unlikely to have hyperparathyroidism, right? Because the levels are low enough, it would seem very unlikely. People who have a level above point B here, probably much more likely to have it because, based on what we know, hyperparathyroidism would probably have a curve more similar to this, and patients this high would be very unlikely to have they're very likely to have a condition of calcium imbalance or calcium metabolism issues. But see, a lot of patients fall into this intermediate range where it's very difficult to determine just on a single test. This is where it's nice to have multiple tests. That way, if one is suggestive, you can have another one to help kind of rule things in or out depending on the situation. So again, multiple tests can be used because maybe you catch a patient at some point in this intermediate period, and then you test them again. Now they're down the low side. So those are things that can be useful when you're looking at a series of results or by utilizing multiple tests. So what you'll find in a lot of labs is that they'll have published ranges of normal values, quote unquote normal values, that they measure. And so if you had a calcium that was beyond the normal range of that laboratory, that would probably require further diagnostic tests. In a lot of laboratories, they'll find that the normal serum calcium level, the upper limit of normal, they would consider to be 11 milligrams per deciliter, which is pretty standard for a lot of laboratories. So if you set the cutoff point for, say, an upper limit of normal too low, then you end up having a lot of false positive abnormal results, and you waste a lot of time and money because then you're having to chase these down to see, okay, is there something going on, when probably a lot of those patients were had no issues to begin with. If you set the cutoff point too high, then you're going to be missing more people that have disease. You're going to have false negative results, essentially. And so there are several things you can do to determine these cutoff points, and it has to do with looking at sensitivity, specificities, and what we're going to look at as being predictive values for a test at different cutoff points. So we're going to use sensitivity and specificity to test how well a test is going to function. And so we need to do this when we know what the actual true disease state is. Otherwise, I can't really give you an idea what the false positives, the false negatives are going to be. And so we're going to see again that this can be put into one of these 2x2 tables, and we'll see how we can calculate things like true positive rate and false positive rate and all those other things along with that. So we'll look at that in the next slide here. So looking at this table, looks like a lot of stuff, but that's okay. Again, I'm not going to be necessarily testing you on being able to calculate things like sensitivity or specificity, but I would expect you to know what's going into and how we come up with these results. So like, how do you determine what specificity is? And to know what that is, you have to know what's kind of going into it. And so looking at this 2x2 table, this looks very similar to what we saw before. We're going to have a positive test result, either has the person either be diseased or not diseased, and you're going to have a negative test result, and the person's either diseased or not diseased. So by looking at this, we can sort of figure out some of the kind of common themes that are going to be incorporated into these calculations. So looking at this, we can see that variable A here is going to be our true positive test rate. So this is going to be the people who had a positive test result who actually had the disease, right? So these are true positive getting here. B are going to be people who had a false positive test result. So again, they had a positive test, but they actually did not have the disease. So this would be a false positive. C is going to be a false negative test result because you have a negative test here and then the person actually had the disease. So that would be one that you would have missed. So false negative. And then you would have true negatives here being D, where you have a negative test result and the person does not have disease. So again, the only true results you're seeing here are actually A, where the person has a positive test and they have the disease, and D, where they have a negative test and they do not have the disease. And so factoring some of these total columns or rows, we're going to be able to get several calculations out of this that can help us to determine what the sensitivity and specificity is for these tests here. So going through these totals, we can see A plus C is going to be all of the people that actually have the disease state. B plus D will be all the people who do not have the disease state. And then looking at this, we'll see that A plus B are basically everyone who has a positive test result, and then C plus D are going to be everyone with a negative test result. And then obviously A, B, C, and D together are just going to be your total of all the people in whatever test you're doing here. Okay, so we're going to go into more detail on these different formulas as we go through and kind of see how we determine what our sensitivity, specificity are, positive, negative predictive values, likelihood ratios. We're going to talk all more about this going forward. So again, as I mentioned, all the people in that first column are going to be everyone who has the disease state. So again, A and C are all the people either had a true positive test result in A or had a false negative result. They still had the disease even despite the fact that the test was incorrect in the case of C. The second column is going to be all of the non-disease subjects. That's going to be people who had a false positive result, B, and again, this is an incorrect test result, and then all the people who are true negatives. So again, they did not have the disease and had a negative test. Now, if you wanted to determine what the prevalence rate of the actual disease is, basically you're going to look at all of the people who actually have the disease state, which would be A plus C, and then you would divide that by all of the people in the study population. So if you look back on that previous slide, you would see it's A plus C divided by A, B, C, and D, and that way you can tell what proportion of the people in the test actually had the disease, and that's your prevalence rate. So to determine what our sensitivity is, this is going to be the ability for the test to actually detect disease when it's present. And so basically you can calculate that as looking at A, which we said was our true positive rate, and then dividing that by A plus C, which would be basically all the people in the testing in the trial that actually had the disease. So A being our true positive rate, and then C being our false negative rate. So by using that as our denominator, we can figure out that when people actually have the disease, how good is the test in actually picking up people who have the disease? That's your sensitivity, your ability to detect disease when it's present. If the test isn't very sensitive, then you're going to fail to detect disease in some of the people who have it, and then you're going to have a larger number of people that fall into category C, right? If you have a very sensitive test, A would be much larger, so your numerator would be much higher, which means you have a more sensitive test, right? In the case of having, like, say, a test with 100% sensitivity, they would have basically no one falls into the C category, and everyone would be true positives in that case, right? But as you have more people fall into C, they're going to see your denominator start to get larger, numerators getting smaller, and then you'll see that sensitivity will start to go down. You could also come up with what we call a false negative error rate, and that's basically we're going to put all your false negatives, and again, your denominator is still going to be everyone who has the disease in that case. And again, that's just going to tell you specifically what is the rate that you're having false negatives appear here. So again, it kind of makes sense how sensitivity and this false negative error rate kind of go hand in hand based on what their denominator looks like, being just all the people who have disease in those cases. Now, what you're going to find is that when you do tests like these in these 2x2 tables, you're going to find that sensitivity and the false negative error rate should add up to 1. And if it does not, then you have something else goofy going on with your tables there. But basically, having the proportion of people who are true positives plus the people who are false negatives, adding those up, you should get 1 or 100% of your people who have the disease state. Now, specificity is going to be the ability to indicate a person does not have disease when no disease is present, right? So you're going to be looking for the ability to actually get these true negatives when the disease is not present there. So you can imagine this is calculated very similar to sensitivity, but your variables change here to where D is going to be in the numerator, and this is the true negatives. People had no disease and the test was negative, and you divide that by D being there, being your true negatives, and then also going to be your false positives there. Now, if you had a test that was not very specific, that means you're going to have several people who are going to fall into the B cell, meaning they're going to be indicated as having disease when they are not actually diseased in the first place. So again, very similar to what we saw with our false negative error rate, we can also sub in into our numerator our false positive value, which is B, and end up getting our false positive error rate. And so again, looking at this, you're looking for your false positive error rate is going to be the number of individuals who the test said you had disease when they actually didn't, divided by that denominator of all of your people who did not have the disease. So B divided by B plus D in that case. And again, what we saw with sensitivity plus the false negative error rate, you should find that false positive error rates plus specificity should add up to be 1. And ideally, if you had 100% specificity, again, you would find that everyone who did not have disease would be categorized as having a negative test result. But again, no test is going to be perfect, and so we're going to see some trade-off here between sensitivity and specificity. So as an example, to kind of put these kind of abstract concepts into a little bit more of a concrete example, let's say we had 80 consecutive people who were entering into endocrinology clinic, and they're having a calcium level drawn as a workup for hyperparathyroidism. And so we're going to say for this particular laboratory, their upper cutoff point for a normal value is going to be 11. So anything greater than 11 would be abnormal. Anything less than 11 would be considered normal, right? So anything greater than 11 is going to be considered a positive test. Anything less than 11 would be a negative test. So here's the 2x2 table of our subjects here. And again, we need to know who actually has disease and who doesn't in order to come up with these calculations. So again, we kind of know a priori beforehand who's got hyperparathyroidism and who doesn't. And so looking at this table, we can see here the actual disease status. The actual disease patients end up having 20 of them out of the 60. I'm sorry, out of the total of 80. And we had 60 people who were non-diseased, right? So again, I'm getting a total here of 80. Now, at least for this slide, we're just mainly going to be focusing on the sensitivity and specificity. So kind of looking at these guys, and then we're also going to be looking at the false positive and false negative error rate here as well. So this is kind of the main thing since we've talked about that already. So some key takeaway here. One, what is the actual prevalence of disease? You can actually figure that out based on this calculation here where they did 20 divided by 80. So the number of diseased individuals out of the entire group that you were testing, and so that ended up being 25%. So you'd have a prevalence of 25% out of the study population that you had there. Okay, so looking at the actual result, the test, we had positive serum calcium levels, which would be any calcium level greater than 11. We had 12 individuals who ended up being a true positive, and then we had 3 false positive individuals. And then as far as negative lab results, so a calcium less than 11 milligrams per deciliter, you'd see that we had 8 individuals who are false negatives. So these are individuals who had the disease but came up as a negative value. And then we have 57 people who are true negatives, people who had no disease and the test came back less than 11, essentially. Okay. So now what we can do with these values, we can actually calculate what our sensitivity and specificity is. So for sensitivity, we're going to take the number of true positives that we had. So in this case, it would be 12. So this would be the cell A divided by the total number of people who had the disease, or 20 in this case. So here we had a 60% specificity. So those who actually had hyperparathyroidism, we were able to detect true positive abnormal test results in 60% of those individuals. Okay. Again, not 100%. No test is going to be 100%. So again, it's kind of middle of the road sort of sensitivity there. On the other hand, looking at your specificity, we're looking at the true negatives divided by our total number of people who had no disease. And you can see here, this is actually much better as far as specificity goes. So 57 out of 60 and 95% specificity. So you could kind of reasonably assume that if someone came back with a level less than 11, a calcium level less than 11, you could be reasonably assured that it's unlikely that they have hyperparathyroidism. On the other hand, though, just because someone has a level less than 11 does not mean you can completely exclude the fact they have hyperparathyroidism, as detected by the fact that we just don't have as much sensitivity, right? Similarly, you could just reverse the values here and come up with your false positive error rate and then your false negative error rate. So remember that when you add up your false positive error rate plus your specificity, that should equal 100, right? 100%. So 95 plus 5 equals 100%. That makes sense. And then on the other hand, your false negative error rate, it would be our 8 divided by 20, or 40% plus our 60%. Again, that equals 100%. So again, these go along with one another hand in hand, essentially. So, and just remember that our false positive error rate, this is going to be our alpha error rate, or the type 1 error rate, right? Because we are saying that someone has disease when they truly don't. And then we are looking at our beta error, or type 2 error, as having people who are false negatives, or they have disease. But we did not conclude that. So this slide kind of reiterates what we talked about on the previous one while looking at the table, but just note that kind of goes to show you that as far as having a relatively low sensitivity, just goes to show you that patients with hyperparathyroidism can have some vacillation in their calcium levels. They might range from very elevated, say above 11, most definitely, sometimes go down to the high normal range. So a value of 10.9 for these patients may be relatively low for someone with hyperparathyroidism, but would still be considered a normal test result in this test here. So again, you can find that by changing your cutoff point, you're able to change how specific or how sensitive these tests are going to be. But again, one thing you're going to find is that in general, when you make a test more sensitive, you typically lose some specificity. And alternatively, when you try to make a test more specific, you end up losing some sensitivity. And we'll talk more about that as we go forward. But just keep in mind that no test is perfect. This will make a lot more sense when you look at these receiver operating curves in just a few slides here. So sensitivity and specificity are, good numbers to have, right? It kind of gives you an idea about the performance of the test, but more important to the clinician is saying that, well, if a patient has a test result that's positive, what's the probability that they actually have the disease? And alternatively, if the result's negative, what's the probability the patient does not have the disease? And so instead of doing kind of a vertical analysis like we did, where the denominator for sensitivity and specificity were either all the people who had the disease or people who did not have the disease, you can find that we can get these predictive values figured out by going and doing a horizontal analysis, where instead we're going to see our denominator are going to be all people who had a positive test result and all people who had a negative test result, respectively. So we'll look at that in the next slide here. So looking at our predictive value or positive predictive value, you see as PV plus there as a way we can abbreviate that. Basically, you're looking at your true positive rate divided by all the people who had a positive test result. So that would be people who had true positives in cell A and people who had false positives in cell B. Okay, this basically indicates that the proportion of people who had a positive test result that happen to actually have the disease. Alternatively, you can get a negative predictive value, which again is going to be able to tell you that, hey, if they had a negative value, what is the actual proportion of those individuals who did not have the disease? In that, you're going to see your numerator here is going to be actual true negatives divided by individuals who had a false negative plus all your true negatives. So if we were to look at the serum calcium elevations, we can see that our positive predictive value is 80%, or in this case would be 12 divided by 15, so 12 being all the people had a true positive result divided by all the individuals with positive test results. And then negative predictive value is going to be this 57 divided by 65, or that true negative divided by all the people had a negative test results, again including the false negatives and the true negatives there. So looking at this, we can see that the positive predictive value is 80% in this case, and the negative predictive value is 88%. Ideally, we want as high values for these as possible. And so you can't really be fully confident. It's considered a B average, but typically you're trying to shoot for a lot higher for your patients, obviously. And the only way you could ever get these to be 100% is if they had no false positives or false negatives, right? But again, medical tests are almost never going to be perfect, and they can make it pretty difficult in order to try to interpret these predictive values. One of the big things you need to know in order to help kind of guide you when you're evaluating these predictive values is actually going to be the prevalence of the condition actually being sought. And so this is one of those things where having an idea of what the prevalence of disease in the population is can actually have a very direct influence on being able to interpret these predictive values. So we mentioned prevalence is just the total number of diseased persons divided by the total number of people studied. So that A plus C, which is your true positives, plus your false negatives, divided by the total number of people being studied. So A, B, C, and D together. So imagine, for instance, that you have a disease that has a 1% prevalence in the general population. You'd find that if you had a perfect test, you'd have one true positive test result out of every 100 people examined, right, based on the prevalence reported there. Now, imagine we were doing the test just like the calcium. We saw there's a 5% false positive rate, which means that there are 5 individuals who had no disease, but they're being incorrectly categorized as having a positive test result. That would mean that out of the 99 people who had no disease, you'd end up having roughly 5 of them coming up with a positive test result. So that would mean that almost 5 out of every 6 positive tests you'd be expected to be falsely positive. So again, not super confident, or doesn't instill a lot of confidence into you to see how well these tests are working. So whenever clinicians are testing for these kind of rare conditions, you have to be prepared that some of the positive test results are going to be falsely positive. And this is why it's always important that we don't make diagnoses just based on one single positive test result, but either do, say, repeat values, or we do multiple tests that can kind of help us to correctly rule things in or out when trying to make our diagnosis. Now, because of the fact that we're going to have these false positives are going to be an inherent problem with any of these tests, especially as the prevalence for certain disease states can go much below 1% of the general population. Does that mean you should never do screening tests for that case? No, that generally means that if you do a general screening and you're going to just inherently know that there's going to be some false positives, it just means you probably need to do follow-up testing, right? And so we're going to look at how we can combine different tests with different specificities and sensitivities in order to try to get us to a more kind of clear-cut diagnosis for your patient. Very rarely, in some cases, you can have what we call kind of gold standard tests, which are going to be these kind of pathognomonic tests, where if you have a positive test result, it almost definitely means that the person has that diagnosis. So there's tests like that for TB, for HIV, things like that. Typically, you find these kind of tests tend to be more expensive or more difficult to perform, whereas kind of general screening tests can be a lot easier, right? It's a lot easier to test for things like a calcium level than it is to get parathyroid levels and other things necessarily. So because of that, this is why we need multiple tests in a lot of cases, but occasionally you may find this kind of gold standard test where you only need that one positive result essentially. So this is an important slide, kind of linking back how we use things like laboratory tests and imaging and things like that to try to rule in or rule out different diagnoses and how we manage our patients, right? So imagine that you're a clinician, you're working out there in the clinic, and a patient presents to you with chest pain, right? Typically, we're going to start off with things that are very cheap to do, very not very invasive, very easy things to try to perform. And so initially, you're always going to do your history and your physical exam, and you kind of start to develop a list based on that of what could explain the chest pain. Is it just musculoskeletal pain? Is it angina? Is it PE? You start to come up with this list of hypotheses. And based off that, you're going to want to start to do these sort of early screening tests to try to rule out false hypotheses, right? So you can start to discard them. So basically what we're going to do is use things like laboratory tests and imaging procedures. And we want these early tests, these kind of early screening tests, to be highly sensitive. The reason why we want a high degree of sensitivity is because, again, remember how we calculate sensitivity is that you're looking at all your true positives divided by both your true positives and your false negatives. So in order to have high sensitivity, you have to have a low false negative error rate. So if a person comes back negative on this, it is very unlikely that they are a false negative, and you can start to rule out that diagnosis, right? So you want tests with high sensitivity to rule out these sort of false hypotheses, right? So this is when you go down to this mnemonic at the end here, this is where we're going to get our snout. So high sensitivity tests are needed to rule things out because that false negative error rate is going to be very low. So once you, and when you're dealing with high sensitivity tests, because of that trade-off, as you have a higher sensitivity, you're also going to start to drop your specificity. We know there's going to be false positive results, but that's okay. I'd rather cast a wider net and have too many false positive results, have too many positive results in general, because I can rule those out with secondary testing, right? I can start to rule things out later on. So really early on, I want high sensitivity tests, so I have a low false positive error rate. So next off, you want to do confirmatory testing. You want to do things that can help to rule in the diagnosis, and typically these are going to be things that are very highly specific. By having a high degree of specificity, that means that your true negative rate should be very high. Your false positive error rate should be very low, so that if someone does come back with one of these positive test results, you can feel pretty well assured this actually is a disease state that they have, or they actually have some sort of abnormality here. And so again, starting off with high sensitivity to start to rule things out, and then finally you end up with kind of secondary testing or tertiary testing that's very specific to rule some of these diagnoses in. Okay, so that way you can be reasonably sure that, okay, yes, this patient has this final diagnosis. I think they have a PE or whatever happens to be, right? So just remember this mnemonic: spin and snout. Spin or specificity is needed to rule things in, and snout, sensitivity is needed to rule things out. Okay, so again, early on you want screening tests which have a high sensitivity, and then later on to confirm a diagnosis, you want things with the high specificity. All right, so in contrast to things like predictive values, we have what we call likelihood ratios, and we'll see that these are not going to be influenced by the prevalence of disease in the same way that the predictive values were. And so basically, we can have a likelihood ratio positive, and we're going to have a likelihood ratio negative. The positive one's the first one we're going to look at. And basically, this is going to be a ratio of the sensitivity of the test, and that's going to be divided by the false positive error rate for the test. And we saw that because those were those kind of vertical analyses, that those were independent of the prevalence of disease, right? Because you're only looking at people who have the disease versus those that don't. And so because of that, the likelihood ratio is going to be independent of the prevalence of the disease, as opposed to, the positive predictive values, negative predictive values, which were. So anyway, so again, you can see how the equation is basically just going to be the positive predictive value, the sensitivity of the test divided by this false positive error rate, just one divided by the other. And so obviously we want to have high sensitivity of a test, right? So these are good because we want true positives, but we don't want false positive, right? So we want this value to be as low as possible. We want the sensitivity to be as high as possible. And so typically, because this is a ratio, you want to see that you want a likelihood ratio that's going to be far larger than 1. So the higher it is, the bigger that ratio is, the more better performing the test is essentially. And so you can start to compare the likelihood ratios of different tests to one another to see, how well they kind of stack up. This is nice because you can start to do kind of comparisons between different tests. But again, in general, likelihood ratios on the positive side, you want these to be much larger than 1. So on the flip side of that, we have the likelihood ratio negative, and basically this is going to be the ratio of the false negative error rate, which is again what we want a small number of, divided by our specificity, which we want this to be higher. So for likelihood ratio negative, you want this to be as close to 0 as possible, because you want this false negative error rate to be very, very small, and you want the specificity to be very, very large, right? As close to 100% as you can get essentially. So the closer it is to 0, the better the test performs. And so generally you want to have a test with a high likelihood ratio positive and a small likelihood ratio negative. The better those are, the better the test is. So moving back to our serum calcium data, we can determine what our likelihood ratios are going to be both for positive and negative. Remembering that our sensitivity was 12 out of 20 or 60%, so the sensitivity was not great here, and then dividing that by the false positive error rate. Now, as you remember, false positive error rate plus specificity should equal 100%. So you could do 1 minus specificity to get that false positive error rate. That's one thing you can do, or just directly calculate it by looking at your false positives divided by the total number of people without the disease. And again, you came up with 5%. If you remember back to that data, you'll see that specificity was 95%. So just 1 minus 95 is 5% roughly. So ratio of these two together, you see is sensitivity divided by this false positive error rate, and that would equal 12. Right, so again, this is a useful number to try to compare different tests together. You think 12 is pretty good, it's a lot larger than 1, but still remember that sensitivity of this test was no great shakes to begin with, because we were incorrectly identifying 40% of those individuals as not having the disease when they actually did. Right, so it's not a great performing test from that standpoint. So looking at the likelihood ratio negative here, we would see that you basically do your false negative error rate divided by the specificity of the test. And again, what you could do in order to get the false negative error rate would just be do 1 minus your sensitivity. You would have came up with the same value here. And if you divide that out, you end up getting 0.421, which again is typically you want this as close to 0 as possible. So we'd like to get that as small as we can. And so again, by comparing these things, you can see, well, this test probably isn't that great performing compared to, say a different test like, PTH levels or things like that. And to take that even a step further, some people will actually do a ratio of the likelihood ratio positive to negative and come up with another value they could again use to evaluate the performance of a test. So if you were to take 12 divided by that 0.421, you get a number of 28.5, and that's not as large as you would like. And a lot of people would consider a test a ratio less than 50 would indicate a pretty weak test in this case. We can see that a serum calcium level of the cutoff point of 11 would not be a great test in order to diagnose someone with hyperparathyroidism. Another way we could have done that was by calculating what we call an odds ratio. Is basically you'd end up taking your all your true results, so your false, I'm sorry, your true positives and true negatives divided by your false positives and false negatives there. Again, you end up getting the same result here. So again, it kind of gives you an idea of how well that test is performing. So another kind of question comes up and they say, well, what if you change the cutoff point for what you consider to be an abnormal test? What if we went from say 11 to say for 13 for our diagnosis of abnormal calcium? What you'll find is that when you start to raise up what your set point is for what you consider to be abnormal, you start to lose more of those people who actually had the disease, and so you end up lowering your sensitivity, right? However, you're going to find that your likelihood ratio positive actually is going to have an improvement. The reason for that is that by raising up your cutoff point, your true positive results are going to be diminished, but you're going to find that you also end up having a larger drop off in your false positive results. So you end up having fewer false positive results, fewer total true positive results, but again, overall the test performance is going to be a little bit better, right? So those that you are, that have a level 13 or higher, you can be pretty well sure that, yeah, they probably have that actual disease, more likely for them to actually have it. And so again, using that ratio of LR positive to LR negative is increasing, despite the fact that you're probably missing more of those diseased individuals, because of the fact that by having a high likelihood ratio positive, having that high level of calcium in an individual would increase that certainty of that they actually have hyperparathyroidism, or at least some other disease that would indicate calcium metabolism aberrations. And then in an extremely low cutoff point, so say we're dropping our low cutoff point, you would have someone who had a value is even lower than that. We give you a pretty high degree of certainty that the actual disease was absent in those individuals. So cutoff point is very important in how you define what your abnormal test results are, because again, you're going to have some people that just fall outside of the norm. If you imagine that a range of normal values was 95% of individuals, right? You only get, say, 2 standard deviations around the mean. Some people are still going to fall outside of that and still be considered normal. So again, all is a matter of how you play with your cutoff points and how well your test is going to perform. And of course, the question is always going to come about those patients who have kind of indeterminate values. You're going to have people that kind of fall into the middle. If you set your cutoff point very high, obviously patients that have a higher value than that are reasonably sure to have disease. Set your cutoff point very low, and they're below that, you're reasonably sure they don't have disease. But it's the people in the middle that you have to really consider from that standpoint. So imagine, some tests will actually have kind of indeterminate or kind of intermediate sort of values there. So imagine like a VQ scan, which is looking at pulmonary aeration and blood flow. You can see that the results can be reported as normal, low probability of a disease, indeterminate, or high probability of disease. And so again, not giving you a definitive diagnosis, but again, just one of those steps along the pathway to give you an idea of how you can rule things in or out and come to a final diagnosis for your patient. So your tests just don't have to be normal or abnormal. You can have multiple ranges that are included on there. And so we have to kind of throw out sensitivity and specificity, specifically due to the fact that we can't really do that with anything more than a 2x2 table. But here's an example we have where we're actually looking at patients who are presenting with signs and symptoms consistent with MI and looking at their creatine kinase levels or CK levels. And so basically what they did was that they had different ranges of CK, various ranges along a continuum, and were able to kind of go back after they determined if the patient had an MI or not, and kind of go back and see what the likelihood ratios were for these different groups. And so looking at this, you can kind of see how they broke up the different categories. So you have very high levels down to kind of more intermediate levels, and then finally low levels here. And so looking at whether or not MI was present or was absent, again, you can't really come up with sensitivity and specificity, but we can come up with these likelihood ratios. Now keep in mind this data was done back in the 60s, and so we're actually testing for MIs very differently than now, but you can at least use it as a kind of a reference for how we can use likelihood ratios. And so the question is, what is the likelihood if my patient has a creatine kinase level greater than 280, what is the likelihood that they actually have a true MI? So you can see when you have a very high cutoff point, people who have values this high are very likely to have an MI, very unlikely to not have an MI. There's got to be a pretty good reason for them to have a CK level that high. And so you can see here that the test is very likely to have caught those kind of patients. And then as you start to drop these cutoff points lower and lower, you're less likely to actually have caught an MI. So looking here between 0 and 39, very few of those patients actually truly had an MI based on their diagnoses, whereas many of them were kind of these, if you use that cutoff point, it'd be considered sort of a false positive. So this is done very frequently to try to determine what's the appropriate cutoff point to, try to make sure that you can rule out certain diagnoses and not lump everyone into actually having it. So cutoff points can be very, very important here. And another way you can describe this likelihood ratio is basically the odds of a disease given a specified test value divided by the odds of disease in the whole study population. And so you can see how when you're looking at these different ranges, you can find that if a value is CK value is higher than 280 or higher, the likelihood ratio was very large, 54.8, meaning that the odds that a patient has a value this high and has an MI is very, very high, right? Versus if you use that lower cutoff point of 39 or less, the likelihood ratio is very small, meaning that if the patient had a value like that, it was very unlikely, the odds are very low that they actually had an MI that was present. It's not zero, but it's very low as compared to using a much higher cutoff point. Now, if you're looking at these intermediate values here, you can notice that it wouldn't elicit quite as much confidence in the diagnoses, but it may say, okay, well, it's high enough to be a concern, but we need to do follow-up tests to see if there's something else going on here. So again, this is where intermediate test results can be useful because it will say, okay, well, if it was 39 or less, we're not going to worry about doing any further workup, but if it was higher than that, then okay, we'll do another test to see, if this MI is likely or not. And obviously, things have changed quite a bit since then, but it kind of gives you a good example to illustrate the point. So the next question is well, how do we decide what our cutoff point should be? What is the acceptable trade-off between sensitivity and specificity? And one way you can do this is going to be with the receiver operating characteristic curve, or a ROC curve, ROC. And so we can use these tests for all sorts of different, or use these kind of curves for all sorts of different tests like calcium, blood pressure, really any kind of value that can kind of fluctuate for these individuals. We want to figure out how do you identify those who actually have the disease while trying to not falsely identify as many individuals as possible. So what you're going to find is that the researchers will publish a set of data, and basically they'll know whether or not the patient actually had disease, usually with a secondary test. You'll find this being done in the literature as when they're looking at new tests to be used for diagnoses of different things. But basically you're going to find that they know basically whether the patient has disease or not, and they will change what their cutoff points are going to be all along this curve to try to determine kind of where the sensitivity and specificities are going to lie. And so this will make more sense when you actually look at the curve itself. But we're going to look at a ROC curve here for blood pressure. And again, this is all fictitious data, but it illustrates the point. Basically, what you're going to find on the y-axis is going to show the sensitivity of the test. So as you go higher on the y-axis, you're going to find higher sensitivities, right? So you're going to have more true positives, less false negatives. And then on the x-axis, this is actually going to be our false positive error rate, which is going to be 1 minus specificity. I'll show you why that is in a second. And so again, because the likelihood ratio positive of a test is defined by that sensitivity divided by the false positive error rate, this is why we do the ROC curves in this way, and it's kind of considered to be a graph of the likelihood ratio positive, because again, you're just looking at that ratio of sensitivity divided by that false positive error rate. So here's an example of that ROC curve that we were just kind of mentioning on the previous slide. Basically, you have sensitivity again on the y-axis, where you can start with 0% sensitivity all the way up to 100%, and then you'll notice this false positive error rate, or 1 minus specificity here on the x-axis. Notice here though that the values of the blood pressure are actually going kind of in reverse to what you might actually think they would be going in a normal sort of curve like this. The reason for that is, you imagine, as if you set your cutoff point very high for diagnosing someone with hypertension, you notice that your sensitivity is going to get lower and lower. You're going to find that it's more difficult to have people who have the disease actually hit a value this high to be classified as having hypertension. So even though your sensitivity is low, you're also going to have a relatively low number of false positive errors. As I start to increase the sensitivity and drop my cutoff point for a positive test result lower and lower, you're going to notice here that even at 120, which we would consider to be normal systolic blood pressure in a lot of patients, even though you would have very high sensitivity, you're going to see that your false positive error rate is going to be super high as well. And so you're going to have a lot of people being incorrectly diagnosed as having hypertension just based on the sole cutoff point here, based on this. But just know that as your sensitivity is going up, that ratio between sensitivity over the false positive error rate is going to get higher, so your likelihood ratio is getting more and more positive here. And so again, typically they're using, researchers are using a large population and they're performing these blood pressure checks, and they are doing it based on whether the patient has the presence or absence of hypertension. And based on that, that's how they can construct that curve there. So you can imagine if you were to set the cutoff points to either extreme, you're going to find there's some problems with that. So imagine if you set your cutoff point to 0 millimeters of mercury. So this is an extreme example. We know obviously if a patient had 0 blood pressure, they'd be dead, but let's just use it as an example here. And so basically all living study subjects would be included in the group suspected of having hypertension, right? Because your cutoff point is 0. Most alive people should have a systolic blood pressure higher than that, I would imagine. So you consider all of them as having hypertension, quote unquote. Now that means that your sensitivity would be 100% because everyone who had actual hypertension would definitely be included in that, but your false positive error rate would be very high as well. And so again, all normal individuals would be have a positive screen for hypertension, including everyone who basically normal blood pressure individuals. So your false positive error rate would be 100% at that point, right? So then that's why you saw in that curve that that would be in the upper right corner. So imagine if you had that curve again. Is kind of going like this. Blood pressure of 0 would be right about this point right here, right? So false positive error rate and sensitivity would be like 100% there. So on the flip side of things, you could use a really high cutoff point. So say for instance, something unrealistic like 500 millimeters of mercury. If you had a patient who had a blood pressure that high, they probably wouldn't have it that high for very long. They probably have blood coming out every orifice they have. But anyway, basically you would expect no one to have a blood pressure that high, and so no one would be detected with hypertension. So basically your sensitivity would be 0 because you'd have all false negatives essentially. And so no false positives either, so you'd have a false positive error to 0. Specificity, here would be 100% in this case. And so again, if you would imagine it being on that curve, you'd see it again being on that kind of lower left corner of the graph, right? So again, looking at this, here would be, say 500 millimeters of mercury at that point. And basically they'll go through and calculate the false positive error rate and then the sensitivity, each of these different cutoff points. So they'll do 120, 130, 140. And they'll go through and be able to kind of connect the points there and be able to come up with this curve. That's how it generates that graph like we saw a few slides ago. Normally what you're going to find is that the best cutoff point is going to be the point where you have the closest to the upper left corner. So again, a corner representing a sensitivity of 100% and a false positive error rate of 0%. It's kind of the goal. Keep in mind that a lot of times those values are not going to be realistic, so you're going to have to back off of that, but typically you're going to find it more go towards that upper left corner there. So looking here, we can see that, again, we would like to go to the point where we have the high sensitivity and the lowest false positive error rate. So the ideal place would be kind of as close to this upper left corner as possible. So, looking at 130, it's pretty good sensitivity, but the false positive error rate is pretty high. 150, the sensitivity is just too low. So maybe something like kind of this Goldilocks sort of point here is say like 140. And so you notice that that's, usually a pretty good cutoff point for hypertension that we have nowadays. And again, this is the one that's kind of the happiest medium. Again, no test was going to be perfect to ever have anything directly in this upper left-hand corner, but you can try to get as close as you can get. And you'll see these curves can differ pretty widely depending on the kind of test that they're performing and what sort of disease states they're looking at. And I'll show you a couple of these curves in a minute here where you can see some that are very excellent and kind of have the best trade-off between sensitivity and false positive error rate. We'll see some that really don't have much benefit at all. So you can see on the different curves here, you can notice the one that has no benefit whatsoever is really the straight line here, where basically there's a one-to-one trade-off. So for every bit of increase in sensitivity, you're going to get more false positives. So really no benefit here. This one would be kind of fair. This curve here would be good. Kind of looks very similar to that blood pressure one we looked at before. But ideally, the most excellent curve you could have would be as close to this upper left-hand corner as you can get. You kind of have these points here that would be very, very good at detecting many people have the disease without having a ton of false positives. So the next thing we're going to look at is a curve that was looking at follicular thyroid tumors and trying to look at the this correlation between diameter of the tumors and the probability of malignancy. And so it's kind of interesting because the initial curve they did really wasn't all that exciting. However, if they divided up patients and those who were less than 50 years and those who were greater than 50 years, they ended up getting much better results, as we'll see here in a second. And just note that it's pretty unusual for a lot of these curves to be as tight as this one is, but they have a relatively small number of patients, and so it's kind of the best curve that they're able to develop. And so we'll be able to compare the older age group versus the younger one. We can see how these points are going to kind of measure up to one another. So for instance, if you're looking at the tumor diameter 4.5 centimeters, the sensitivity in older patients was about 75%, but only 35% for the younger patients. And then the corresponding false positive error rates was 0 and 25% respectively. And so we're going to look at these in just a second here, but just kind of keep these points in mind as we look at the graphs. So again, this upper one here being the older patients, not normally what you would see, but again, this is going to be based on again, they have a smaller number of patients, and they were kind of using their cutoff points as they were kind of setting them up. So again, anyone at 3.5 centimeters, they calculated the sensitivity and the false positive error rate, and they got plotted there. Now again, the original line kind of showed no benefit. You'll notice here that the younger patients versus the older patients, how they can kind of compare. And looking at things like 4.5 centimeters, here they had really high sensitivity compared to the younger group. And again, that's pretty consistent between 4.5 to 3.5. And so here, if you were looking at this, you can notice, okay, well, if I went down to 3.5 centimeters for this older patient group, I'm not getting any more sensitivity, but I am getting more false positives essentially. So maybe 4.5 centimeters would be a better cutoff point for them. And so again, this all kind of goes back to the author's kind of assessment of this and them saying, okay, well, this is what we think is the best cutoff point in order to maximize both sensitivity and the false positive error rate. And one of the ways you can actually compare either different tests, or in this case, when you're looking at different age groups, is to look at the area under the curve. And so basically, the greater the area under the curve, the better the test, because more of it's kind of filling in more the graph essentially, and you're closer to getting that upper left-hand corner there. And so, for instance, if you're looking at the older patients, you saw that it was nearly 90% of the curve fit under there, whereas with with the younger patients is maybe close to 60%. So typically, the bigger the AUC, the area under the curve, the better the test is actually performing in these cases. And so you could conclude, if a surgeon was deciding whether or not to take out this tumor, for older patients, you could use the size of the tumor in order to determine malignancy, but probably not so useful for the younger patients. And so, clinical real-world decision you can make based off of data like this. All right, so that's going to be it for the section today. If you have any questions, please feel free to let me know, and I'll see you guys next time. Thanks. Bye.